Good evening, everyone. Thank you for joining in on time. So, the talk for today's evening is thin endometrium, what to assess, and how to act before transfer. So, why this topic we have specifically chosen? Because this is one topic where we don't discuss too much, we don't understand the pathology. Therefore, the treatment also is many a times like an empirical therapy, but it should not be. There is a methodology which you have to follow for you to be sure what you are dealing with. So in today's talk, the key questions which we are going to discuss, how to define thin endometrium, how to diagnose it, what are the causes, and how to manage it. Finally, that's the main thing. Robert Edward once said that thin endometrium is the last step or barrier in ART. Why? We all know once we have a good embryo, we need a good soil for the embryo to grow. So what we need? We need good endometrium. And endometrium is such a tissue which can regenerate. We know endometrium regenerates every month. So despite having this ability, still thin endometrium is what we mostly encounter in cases of recurrent implantation failure, where if you are transferring a euploid embryo and still you're not getting success, it is telling you that there is some problem in the endometrium. Now, why are we so concerned about endometrial thickness in ultrasound? Specifically, if you talk about thickness, see, thickness is a measure of endometrial receptivity. So it's not only thickness, we have so many things, we'll discuss about that. But what we need to understand that whenever the endometrial thickness is less, the chances of pregnancy is the likelihood goes down. So this is our main concern. Endometrial receptivity on an ultrasound, if you all are doing ultrasound, you do know we look at endometrial thickness, we look at pattern, we look at flows, like whether the flow is in zone 1, zone 2, zone 3. We can do vocal to calculate the endometrial volume. We look at endometrium ultrasound, structural ultrasound abnormalities like fibroid and adenomyosis, which may hamper receptivity. So among all this, what we choose specifically in our day-to-day practice is endometrial thickness. Why? First of all, it's easily measurable. The chances of having intra-observer variation is also very less, and it directly correlates with estrogen levels. So this is the most simplest marker which we use for saying that endometrium is receptive and our chance of having good outcome of our IVF or IUI cycles is there. Now, if you look at this meta-analysis which came in 2019, what they said that thickness and pattern are two things which you should be concerned of. Apart from that, measuring volumes or blood flows or other things is not necessary. Only if you are doing two things, looking at the thickness and looking at the pattern of endometrium. What do you mean by pattern? We'll discuss about that. Pattern means endometrium is like in the menstrual cycle, we know the endometrium changes. Normal appearance of endometrium changes. Let me show you the photo image of normal endometrium first. So please see this image. This is a normal cyclical changes which you encounter in a menstrual cycle. So when the patient is already menstruating, you know it is very thin. It's just like a single line. But as the estrogen level rises, the endometrium grows and it attains a leafy trilaminar pattern where the borders and the center is hyperechoic. And in between this, we have hypoechoic layers. So this leafy pattern is always maintained. This is how you see endometrium in the proliferative phase. By secretory phase, when the progesterone comes in, what change happens? This hypoechoic zone is lost and you see this hyperechoic endometrium. So if you don't know which phase of menstrual cycle the patient is, just looking at the endometrium, you can say, okay, she might be in secretory phase or menstrual phase or proliferative phase. You can pick that up just by seeing your ultrasound. Now let's go back. So when we talk about endometrial receptivity, we need to look at two things. First is the thickness. Second is the pattern. How you measure thickness? You measure from one border to the other. Don't include the myometrium. Point number two, if you have fluid in the endometrial cavity, kindly don't include that. Okay. Now, whenever you have a thin endometrium, why we are saying that IVF or IUI or OI, whatever ART procedures you're following, why the outcome is poor? The functional layer of the endometrium is thin when you have a thin endometrium. What happens because of that? The embryo is in direct contact with the basal layer, and here the oxygen supply or the blood supply is more. So there is more oxidative stress to the embryo. Embryo doesn't like to stay in such high oxidative stress. Therefore, your chances of having poor outcomes in form of failed IVFs or miscarriages or ectopic pregnancies or low birth weight, all of these complications you can have. Now, if we take a cutoff of 7 millimeters, around 2.4% is the reported incidence of thin endometrium. But is this cutoff fixed? Should you not act if the endometrium is less than 7 millimeter? No, not at all. Please look at this paper which came in 2018. And if you can focus here, in cases where they have actually taken 40,000 embryo transfer cases, and in patients where they were doing fresh embryo transfers, where the endometrial thickness was between 5 to 5.9, still 18% of the patient achieved live birth. Similarly, in frozen embryo transfer, if you can see, around 15% patients had live birth with thin endometrium of 5 to 5.9. So there is no particular fixed cutoff which you should use. The cutoff which we usually follow is around more than 8 mm. We should have around 8 mm is minimum what we require in fresh, and in frozen up to 7 mm. Below that, we know the receptivity is low, and we can try next cycle. We can see what is the cause, why the endometrium is not growing, whether we are not giving estrogen properly, whether the blood flow to the uterus is problematic. There are so many things which we need to keep in mind when we are dealing with the case of thin endometrium. Now, how do these patients come to you in OPD? They may come with complaint of decreased bleeding during the menstrual cycle. If you ruled out other things like PCOS and thyroid and other problems, they may come with infertility. They may come with complaints of recurrent implantation failure. So mostly these patients, because endometrium is not growing properly, they will come with such complaint to your OPD. So in history, what are the important points? For what you need to ask to the patient is whether there is any history of any surgery, DNC, any kind of infection, be it tuberculosis, be it PID. India, we know tuberculosis is the most common thing which we have to rule out. Another important thing which you need to see is her previous reports. What you need to see in the previous reports is whether the patient, despite having good ovarian reserve, for example, you have a lady whose reserves are good, but still, because in spite of that, the endometrium is not growing. It is always thin, 3 mm, 4 mm. I have a case. I'll share a live case for you. The case is not for infertility per se. The patient came with scanty bleeding and amenorrhea for 6 months. I took the history. She was on ormeloxifene. So I thought, okay, 8% of patients who have received ormeloxifene may have such complication. So I said, okay, we will just stop this and we will see. We stopped that medicine. We gave the patient, we did ultrasound. What we could found on ultrasound, that there were few adhesions. And I suspected Escherman. I did SIS, and in SIS, I confirmed that there is some Escherman just near the posterior and the fundal region. There were few fibrin strands seen on saline infusion sonography. So when I asked the patient, then she disclosed a history of DNC, which was done a few months back. Now, patient didn't had any withdrawal bleeding because I had tried Meprate, no, nothing, no bleeding. What I did, I gave E plus P regimen to the patient. Patient had bleeding now. Now, gradually her cycles, I'm trying to regrow the endometrium. I have given, because she's recently married, one abortion, that was a missed abortion. So she had a DNC. So I'm trying to grow her endometrium, giving medications, because I know if I don't correct it now, next, what she will present is with infertility. That was the most common presentation. Now she's going to come back. Now, what are the causes? See, causes can be multiple. It could be hormonal, like hypo cases, premature ovarian failure, hyperandrogenism, prolactin disorder, could be due to inflammations, which could be due to anything, tuberculous or non-tuberculous endometritis, whatever, be it PID, iatrogenic causes in form of DNCs, radiation, septic abortions. Among all these causes, hormonal Yes, we all can revert. Inflammatory to some extent, yes. But iatrogenic causes are the most difficult to treat, and these causes is not easily treatable. And the worst outcome we get when we are dealing with such cases. So, what should we evaluate when you have a patient with thin endometrium? You have taken a history. First of all, start doing TVS by yourself. Do TVS for your patient, because when you know the clinical history, you know what you need to look for. Next is you have to look for hormone profile, do your thyroid, prolactin, LH, FSH, see what is the cause. Infection screening, look for structural malformation in the uterus. See the treatment also. Many a times we give premature progesterones. We give clomiphene. We know clomiphene has an anti-estrogenic effect on the endometrium. Look for vascular causes. Many patients where the uterine artery pulsatility index is more than 3 or the zonal flow is less, those patients also need separate medication. See, for example, you have a patient where uterine artery PI is coming high. You know the blood flow to the uterus is not good. Resistance is high. What you need to do? You need to give aspirin. But when you know the cause, you can treat it. But this will not be okay if the patient has some infection or if patient has some treatment related issue, then you have to treat that cause. So you keeping the differential in your mind is going to help you in deciding what medicines or adjuvants you need to add for that particular patient. Now, patient may need autoimmune evaluation because autoimmune disorders can present with thin endometrium. And lastly, we might do a molecular testing also. Are you aware that the endometrium also ages like our ovarian reserve? We know a lady of 40 years will have low ovarian reserve as compared to a lady of 30 years. Similarly, the endometrium, if you compare thin endometrium prevalence, it is around 25% in women between 41 to 45 years, and the prevalence is less than 5% in ladies who are less than 40 years. So this also you have to keep in mind. This is something which you cannot correct. As you cannot reverse ovarian aging, you cannot revert endometrial aging also. Now, is the success of embryo transfer related to thin endometrium? Please look at this paper which came in Fertile Sterility Journal in 2013. And if you can read here, the patients who were diagnosed with thin endometrium and the cause was not adhesion, there the outcome was better as compared to patient where thin endometrium was due to adhesion. Same thing was reported in this paper, which came in 2024. If there is Asherman, the chances of having pregnancy is the lowest. Now, I told you pattern also matters. Please see, there, we discussed that there is a leafy pattern. Many a time this leafy pattern may be disrupted. It could be partial leafy, it could be non-leafy, or you cannot just see the pattern. Why this leafy pattern is disrupted? It is mostly due to fibrotic changes which may happen in the uterus due to some iatrogenic injuries or due to pathologies like adenomyosis. Therefore, pattern is very important. This is second thing which you have to focus when you talk about endometrium. So if you're doing scan, okay. If you're not doing scan, whenever you get your images, kindly just open your image and see whether the pattern is maintained or not. This is how a normal endometrial pattern looks like. So if you have done in proliferative phase, you should see a trilaminar leafy pattern. Now, in IUI cycles, specifically what we use in IUI, mostly we are using either clomiphene or letrose. Among these two drugs, if you compare, we know CC or clomiphene citrate has an anti-estrogenic effect. So therefore, it will lead to thin endometrium as compared to letrose. But it's not significant. It's if you talk about live birth rate, it doesn't affect that. Yes, if you talk about gonadotropin, among all these medications, gonadotropin causes best endometrial growth. But this growth of endometrium is not a deciding factor for you to transfer a cycle if you have planned a IUI cycle. See, one more concept you need to get in. There is something known as constitutionally thin endometrium, where you have ruled out everything and you have seen that patient in natural cycle, she is having normal bleeding. She doesn't have any other complaint. You do scan for that patient and she had a endometrial thickness of 6 mm. So that 6 mm or 6.5 mm may be normal for that patient. So in that lady, if due to any reason you started OI for that patient, you may not get a ET of 9 or 10 mm or 8 mm. For that lady, 6 mm may be okay. So you have to understand the difference between constitutionally thin endometrium and pathologically thin endometrium. Now, how will you know that? The best way is to review the reports to see before she has entered this infertility treatment or other things in natural cycle, what was her endometrial thickness normally, how much her endometrium was growing, you need to see that. So when you see that, you will have an idea. And second thing, what you need to do, you need to evaluate the patient. Whatever we have discussed till now, you need to look at that and see if you find a cause, you can treat it. Now, in fresh cycle, if you have planned to transfer embryo in that particular cycle, what you can do if the endometrium is not growing appropriately? You can change the protocol, whatever you are following. For example, if you are following antagonist, you can go to agonist. You can add estradiol. You can increase the dose of estradiol if the patient is already on. You can give adjuvants. And if everything fails, the best is to just preserve the embryo in next cycle, see what is happening, rule out everything, and then you can do a frozen transfer. Finding out the cause is the key for management. Until, like, for example, if you have a case of chronic endometritis, there is fluid in the endometrial cavity. And if you have suspected chronic endometritis, you need to treat chronic endometritis before you go for an embryo transfer. Now, what are the treatments? I told you there are treatments, adjuvants. You have so many options available. How you have to choose now, that we need to discuss. So there are hormonal strategies. You may go for estradiol. You may change the route of the estradiol. You may use growth hormones, HCG. Many adjuvants like GCSF, vitamin E, PRP, sildenafil and pentoxifylline, aspirin we use. Surgical method which people use is using endometrial scratching. Now we are going to discuss each of this and we'll come to a conclusion what is clinically proven or clinically relevant, and we'll try to make a summary so that we can use this in practice. We will try to simplify it as much as possible. Now, if the patient endometrium is not growing, first thing what you do, you know endometrial thickness. For growth of endometrium, what you require, you need estrogen. So what you do, you add estradiol in that patient. You may start from 2 mg TID. You may keep on increasing the dose. We know as estrogen will increase, endometrium will grow. So you can go up to 12, 16 milligram. You can increase the duration of estrogen exposure in that patient. If oral dose you are scared because we know there is a risk of VTE, what you can do in those cases, you may switch. You may start vaginal estrogen or you may go for transdermal estradiol you may use. Next thing what you can do is using the GCSF. Now, this granulocyte colony stimulating factors will act both in autocrine and paracrine manner and help in growth of the endometrium. How we use it? See, I know all of you might have done IUI. So it is very simple. Just take your IUI cannula or any syringe or anything which goes in the cavity, whatever you are using. 300 microgram in 1 ml of GCSF you will get. Just instill it intrauterine. This is the best way. If you're doing it for thin ET, you can even give subcute also. But in recurrent implantation failure, we give subcute only. If the endometrium is not growing, you can repeat once again. So this is how we use GCSF if required. GCSF, if I talk about the data and study, what the studies are saying, various RCTs, meta-analysis are published. And if I come to conclusion, they say that, yes, the GCSF, if you're giving it, it is going to improve your endometrial thickness. But is this increase in thickness going to give you live birth rate? That's a question mark. So still now we are not sure whether this increase in thickness is converting to live birth rate. But yes, the endometrial thickness, therefore the endometrial receptivity is improving if you're using GCSF. This is same thing is said by ASRM. There is insufficient evidence to recommend for or against it. Yes, if you want, you can use it, but try to use it in a research setting. Why research setting? Because see, more and more data, we are the doctors, we are the people who are going to add data. So if you have, for example, you have patients, 2 or 3 patients, try in one patient, give GCSF, try other thing in other patients, see how the patients are responding. So this is how we should use these strategies, which are very new and new modalities. Now, next best thing is PRP. We know PRP is used for everything, be it hair growth, be it burn dressing, ovarian rejuvenation, PRP injections, and it's a very simple and it's very cost effective. You just need to take patient's blood, centrifuge it, prepare 1 ml of PRP, and instill it intrauterine. So this is not something very difficult to procure or very difficult to use. But if you look at the studies and data, I'll come to the conclusion. All of the studies said that endometrial thickness is increasing when you're using PRP. But the drawback is the number of participants, if you can see, maximum in this study, which was by Russell et al., 85 patients were enrolled, where they used PRP. So our issue is the number of patients. For anything to come in guideline, we need more robust data, we need more patients. But still, whatever preliminary data we have, it is suggesting that PRP is a good option in patients where the endometrium is not growing. Now, next is HCG. We know what HCG does. HCG is a hormone which is responsible for continuation of the pregnancy. Now, how to give? Similar. Take your IUI cannula, take your HCG around 500 international unit and give it 24 to 48 hours before the embryo transfer. Or if you're doing IUI cycles, give before, on the day of trigger, when you're going to give trigger, that is before ovulation, just give it. It is going to improve your endometrial thickness. Other things what we do, sometimes our immune system is also responsible for not allowing the endometrium to grow properly. So in those cases where you are suspecting autoimmune thing or where the flows is less, what you use mostly, you may use immunomodulators. So what we mostly use is either IVIGs or anti-TNF alphas or entralipid. IVIG is something which I have seen being used not for thin ET, for other conditions, but the cost is very high for IVIG. It will cost in lakhs. So affordability is very poor for IVIG, if I say per se, for thin endometrium. Patient cannot, first of all, for IVF and other cycles, patient is spending too much. Spending for IVIG is a question mark. I have never seen being used, but still, theoretically, you can use it. Other things which we use profoundly is aspirin and heparin. This combination, pretty sure everybody would have seen being used. Yes, do understand how aspirin and heparin works. So it's going to improve your blood flow and ovarian uterine perfusion. So it is going to improve the estradiol which is produced. It will reach the endometrium more and the proliferation will increase. Steroid is specifically used in cases of autoimmune conditions where inflammatory causes have been identified. What new thing people have started using, because we cannot use IVIG, it is very costly. We can use, I'm not saying cannot, means the cost is our constraint. So what is the other option? Instead of that, we can use intralipid. Just before embryo transfer, a week before, what you have to do, just take your intralipid. It is a synthetic product where there is mixture of yolks, glycerines, and soybean oil. You can just take it, instill it, and put it. So it is very cheap as compared to IVIG, and it's not a blood product. That's the best thing. So you can even repeat it if you are suspecting some autoimmune cause. Other adjuvants which we commonly use is aspirin, nitroglycerin patch, vitamin E, sildenafil, and L-arginine. Aspirin, we use low dose of 75 milligram. Vitamin E, how do I give it? 600 in the morning and 400 in the evening. Sildenafil, vaginal route is best, but many patients may have burning, all those sensations. So 25 mg TID to QID we give. L-arginine in dose of 3 to 6 gram per day is going to help you in improving endometrial receptivity. In surgical method, what people started using is, let's scratch the endometrium. When we scratch, obviously the endometrium has a capacity to regenerate. It will regenerate. That was the concept. But if you look at the data in this Cochrane analysis, what they found out that even if you do this endometrial injury, you don't achieve much success in live birth rate. So still, we are very unclear whether the scratching is going to help us or not. Now, coming to the role of probiotic. When you need to give probiotics to the patient, treatment of chronic endometritis is not just doxycycline. You need to add probiotics. Why? See, in endometrium or in the vagina flora, there is a symbiosis which is maintained. When the lactobacilli is the amount of lactobacilli is hampered, what we have something called as dysbiosis. So we need to correct that. So whenever you have fluid in endometrial cavity, diagnosis of chronic endometritis per se is very difficult. You have to do CD138 gene on immunohistochemistry and all those things. Look for plasma cell on biopsy. You need a trained pathologist. But many a times we work in peripheral setting where doing tests like big tests like Ellis, Emma, all these are tests for chronic endometritis for picking up what infections you have and what are the specific antibiotics which you can use is not possible. The cost of test is around 30,000 rupees. What we can do in your ultrasound, if your radiologist is reporting or if you are reporting that there is free fluid in the endometrial cavity, and if you don't have option of doing testing for chronic endometritis, start the patient on doxycycline along with probiotics. That is going to improve your local lactobacilli and decrease the dysbiosis which is present in the endometrial cavity. Now, if we talk about the guidelines about how and what to act, if you read all this entirely, everything it says that don't transfer in fresh cycle if the endometrial thickness is less than 8 mm. Better is just freeze it and we will see what it is. Just see, find out, and then go. See, adding one thing I want you all to understand, estradiol we spoke about. You can add estradiol in frozen, not in fresh cycle. In fresh cycle, you are already giving drugs like clomiphene or letrozole, or you're using FS, recombinant FSH or HMG, whatever you're using, you are already having supraphysiological level of estradiol in the patient's blood. If that amount of estradiol is not helping the endometrium to grow, you adding estradiol is of no use. So in this group, there is no role of adding estradiol. For frozen, they say whenever you have a thickness of less than 7 mm, just wait, don't transfer in that cycle, try to find out the cause and change the protocol. For example, for frozen embryo, you plan for natural cycle, then okay, convert it to hormone replacement, HRT cycle. You need to find out the cause, you need to change the protocol before you decide when to transfer. Can you increase the duration? Yes, you can, but you have to keep in mind that when you are increasing oral doses for longer duration, you are increasing risk of VTE. So kindly shift to vaginal or transdermal route. There are various regenerative therapies which are coming in nowadays. We have started using stem cells. This is now in research. Mesenchymal stem cells are being used. And if you look at this paper, here, this was by Professor Nagori et al. This is Indian study. Many studies are there where they have found that using this is going to improve your endometrial thickness, but still we are very naive in this. It is something new which is coming in few years, we may start using it. See, PRP is now, many people are using. PRP, HCG is routinely now being used because those are not costly interventions, which is very costly. So those are few interventions which you can use if and when required. Now, what are the take-home message from today's class? Thin endometrium is infrequent but a challenging thing. You need to understand the difference between constitutionally thin endometrium and pathologically thin endometrium before you go ahead with transfer. When does the pattern matter? See, for example, you have a lady whose endometrial thickness is of 8 millimeter, but it is all zigzag irregular. Do you think that 8 millimeter is good enough for that lady? No. That 8 millimeter with that zigzag pattern is telling you that there is some injury in the endometrial cavity. So you need to find out the cause and correct it. Therefore, rather than using a fixed cutoff of 7 millimeter, try to individualize the approach in cases where you have thin endometrium. Asherman is the most difficult thing to treat. So whenever you have such patient, kindly do adhesiolysis. How you treat, like mostly what we do if you have a case of Asherman, first is the diagnosis. The best way is to do 3D or do a saline infusion sonography. That is the best way for you to treat Asherman syndrome. Once you have diagnosed, kindly go and do a adhesiolisis. After hysteroscopic adhesiolisis, put condom catheter for 24, 48 hours and then start estradiol, continue that so that you don't allow adhesions to reform. Now, if I have to conclude management, so first of all, find out the cause. If the lady who has come to you has a high uterine PI, zonal flow is less, what you need to do, you need to increase the flow. How will you increase the flow? You will increase the flow by adding something which is vasodilators. So what you can use in those cases, you can add aspirin in those patients. You can even add sildenafil. In cases, sildenafil with pentoxifalin is a good combination. If in cases where the uterine flows are normal, zonal flows are okay, still the endometrium is not growing, you don't find any cause, starting the patient on estradiol is the best way. If estradiol is not acting properly or you try to increase the dose, you went up to 12, still you are not able to achieve your endometrial thickness, add vitamin E. Many patients do respond. In my patient, I started her on vitamin E. In next class, maybe I'll try to update how is her outcome. This cycle, I started her on vitamin E. So this endometrial thickness measurement is important. More important than measurement is for you to decide which way to go. In patient where you have infections, your treatment is antibiotics plus probiotics where you are dealing with chronic endometritis. If you have a case where adenomyosis is causing thin endometrium, where adenomyosis is causing the structural abnormality, what you need to do? You need to give pre-treatment with GnRH antagonist. Elagolix is freely available. I think 700 rupees one strip of medicine come average. So it's not very costly medication. So if and you have an oral drug. So what I prefer giving is GnRH for antagonist for 3 months. So with that 3 months, what I will gain the time period where the endometrium, where the adenomyosis will go down, endometrial environment will improve, and my chance of having good endometrium when I am doing ovulation induction will be there. So this is all about thin endometrium. We have an upcoming session on non-invasive prenatal testing. This is something which we mostly confuse. We always quote 99% detection rate for Down syndrome. It's not 99%. Let me tell you. NIPT, I want to end here by telling you that the word itself is a misnomer. I'll start with this term. Why misnomer? Because you do double marker, you do quadruple. Everything is non-invasive. You're not doing any intervention in the patient. So why this? Why the hype of this test is? We have to discuss that. I'm not saying this is a waste test or bad test. It's a pretty good test. It's a very good test. But you need to understand how and when to use this. We have this session on 16th June between 6 to 7 p.m. Do join in. Any query, I'll be happy to take. If you have still any doubt about diagnosis, management, what test you want, if you want me to revise again how we should approach, we can do that also. So just let me know in the chat box. Okay, there's a question asking, does dose of GnRH antagonist in adenomyosis and for how many days in the cycle? It is 150 mg OD, single dose, just 150 mg. And for 3 cycles, this is not something which you have to stop. It is GnRH antagonist. So what you have to do here is just give single dose of 150 mg OD for 3 months. That is continuous. It's not, you don't have to stop. So somebody is asking to repeat once. Okay, so let's start. First thing, patient comes to you, patient's complaint is, there is thin endometrium, there is no bleeding, I just have spotting, you have done thyroid, everything you have done, you don't find anything, you go for ultrasound, you see that the endometrium is very thin. The patient might have infertility also along with that. Now, what you need to do, you need to evaluate. You have three. I gave you a chart. The chart says, let's go back to the chart also simultaneously. Okay, I don't know, it's not moving now. Yeah, so I gave you the chart. The chart says that you have 3 routes. First, look for causes hormonal. In hormonal causes, what you have to do? You have to do TSH, LH, FSH, prolactin. You have done all those things. If all those things are normal, you might suspect, if you're suspecting premature ovarian failure, that also you have to keep in mind. Then you have to rule out Turner mosaic. You have to rule out FMR gene mutation. All those things you have to do. You have done all those things, everything came out to be normal. Now, if that is normal, ultrasound is just showing thin endometrium, then next what you have to do, you might have to rule out tuberculosis, ask the history to the patient about weight gain, cough, night sweat, all those things. You might send the menstrual blood for PCR. You apart from Montague's test and all those things, you might do what you do for TB analysis. Once you have done that, if that comes out to be positive, okay, you may go for ATT. If that's negative, you might test for chronic endometritis. For that, you have to look for plasma cell in the endometrial biopsy, or you may have to do immunohistochemistry where you have to look for CD138 cell. So those things you have to see. If you have diagnosed all this, if still you don't have any diagnosis, then what you have to see, you have to rule out and go properly in the history. If there's mostly what people hide is about septic abortions or unwanted pill intake where they have undergone some DNC. So these things is also important. If you have ruled out everything, then it is idiopathic. Then what you should do, see if the patient has her reports, or if you by chance, if you get some old reports where if you could see her endometrium, you can review that also. Once you have come to a diagnosis, if it is due to hormonal, correct the hormonal cause. If it's due to infection, treat the infection. If it is due to adhesion, adhesiolysis. If due to tuberculosis, treat that. If it's everything has failed, look for autoimmune causes. Many patients with autoimmune disorder also may present with thin endometrium. If you find out that, you have to treat with steroids. And if you find out that the blood flow is less, you have to treat with aspirin and heparin. So this is how you have to decide. Once you have decided, okay, this is my cause. In my patient, the endometrium is not growing due to this particular reason, you have to treat as per the condition. So first you need to work out on what is the condition you are dealing with. What are the options of treatment also we have discussed. Option of treatment is this table I want to show you again. Yeah, this is your option of treatment. First thing, always what you start is giving estradiol. You start with 2 mg TID and then you can hike up the dose. You can go up to 12 mg or 16 mg. You may go change the route also. Apart from that, if only estradiol is not working, what you need to do? Yeah, sorry, I don't know, it got disconnected. So, 1 second, what was the question? I lost the question, yeah. See, final LS surge is due to estradiol. After the LS surge, there is an estradiol surge. It is not going to affect the LS surge. We give estradiol for endometrium growth, and once the final surge happens, then only the ovulation will happen. So it's not going to affect. What is that conjugated estradiol? Estobet. I don't know what is estobet. See, estradiol, we have two forms, valerate or hemihydrate. Hemihydrate is best for vaginal use if you can get it. It's difficult to procure. So mostly what we use is estradiol valerate. Any other question? Doxycycline for chronic endometritis, how many days? So chronic endometritis, we give for 14 days doxycycline, 100 mg twice daily for 14 days. And add some pre-probiotics along with that for 2 weeks. Just aspirating that, many a time people do what they do, they just aspirate that fluid out, then they do their IUI or embryo transfer, whatever it is. Just aspirating is not going to help you because many a times it will keep re-accumulating. So that is not enough. Yes, repeat course is required many times. The question says chronic endometritis, one antibiotic is enough. See, we don't give one antibiotic. Mostly what we give is a combo of doxy and metro. So that is what we give. And repeat course may be required many a times. What not repeat, what we do, we prolong the duration because chronic endometritis is something which requires sometimes may require longer duration. And the largest what I've seen is of 28 days being given. Yes, that patient needed 28 days, and after 28 days, because that is difficult to treat. But most of the patient will respond to 14 days course. And if it is still reaccumulated, I want to tell you that rule out other things apart from chronic endometritis. In many cases of PCOS, many cases of adenomyosis, I have seen that because in adenomyosis also, there'll be fibrosis. And what is chronic? How we suspect chronic endometritis? We suspect that by just seeing fluid in the endometrial cavity. So just rule out there is no other thing. It is chronic endometritis or not. You have to be confirmed. If the fluid is not disappearing, you have given antibiotics, probiotics, first be sure whether it is due to infection only. In those cases, yes, please go and test for chronic endometritis. Next question is, how do we know the resolution of inflammation in endometrium? See, if the endometrium starts growing properly in your cycle, in the next cycle, your job is done. Your job is just to, if you have removed, you have treated everything and you see a good response, yeah, that means the endometrium is functioning properly. See, in a lady who was growing endometrium of 7 or 8 millimeter or 9 millimeter, suddenly if she has a thin ET, there is some cause. So you need to find out if it starts going back to normal, what it was, it is normal. Ma'am, Asherman, after E plus B, what protocol can be given for conception? No, the protocol doesn't depend on Asherman. If you have treated the Asherman, if the endometrium is growing properly, then you can start with anything. The best is gonadotrophins. Why? Because the best growth of endometrium you will get when you're using recombinant FSH and LH. That is HMG mostly what we use. So no more new questions I could read. These were the questions. Any other questions? Try vitamin E. Vitamin E shows a beautiful response. How to improve blood flow to endometrial lining? Aspirin. Aspirin is your answer. Best is aspirin. If that's not working, you can also start sildenafil. You know sildenafil is a vasodilator. It's going to increase your blood flow to 25 mg QID or TID. You can use oral or vaginal. Both are good. Vaginal is best, but many a time patients are not okay in vaginal medications and it do cause burning. Some patient may have burning. So if they are symptomatic, change to oral. Aspirin and sildenafil is good option for you. So mostly, see, if you have started aspirin in next 1 cycle to 2 cycle, if it has to work, it will work in 1 or 2 cycle. You will see some change. So if it's not responding, then no use. How long E plus P should be given for Ashman? At least 3 cycle is the minimum what we need. Many times, if like you start seeing response, but it's not reach your trademark, you may go for 6 months. 3 months, mostly patient respond. The question was how long should we give E plus P regimen for Asherman syndrome to regrow? Nobody asked about vitamin E, but I'm telling you, vitamin E, if you start using, this is something very less harmful and it's an antioxidant. You all know. So vitamin E is going to give you good response. I have seen in one of you patients. This patient, which I told you is not infertility, she has thin endometrium with Eshelman, which is treated now. And now I am trying to regrow her endometrium. That E plus P regimen is done. She is getting her cycles now regularly now, but still my concern is maximum endometrial thickness, which I got, is around 3 to 4 millimeter. So that's why only scanty bleeding and spotting she's having. So what I'm planning now, I want to increase more flow. So I'm just increasing the dose. Normal thickness of endometrium, day 5 with stimulated cycle. There is no normal thickness of endometrium on day 5. See, on day 5 means you have started your letros and you're taking your day 2. So if after those 5 days, if you're talking, means at that time your endometrium will be around 6, 7 mm. See, endometrial thickness is not something which is fixed, and mostly you start measuring or the endometrium when the follicle is growing. First thing is you have to see whether the follicle is growing or not. If the follicle is growing and if it is producing good amount of estrogen, you should see endometrium growing. So when you start your follicle monitoring by day 9 or day 10, so at that time when you start it usually start with 5, 6. Some patient may have 4 also, but eventually it will pick it up. So there's no fixed something. So you are talking about proliferative phase, it can range between 4 to 8. So that is the cutoff what is there. Non-tuberculous endometritis treatment, what should be given and how long? Non-tuberculous endometritis, we are specifically talking about chronic endometritis. So we treat with doxy plus metro for 2 weeks minimum plus probiotics. That is the treatment what you should give to the patient. If the patient is already pregnant or is you are seeing like she has missed her period, at that time doxy you cannot use. So there you can switch doxy with azithromycin of 1 gram start dose. So now no more questions are there in the chat box for me to answer. We had a good discussion. Okay, luteal phase support, which do you prefer? I prefer using vaginal progesterone. That is sustain is my go-to. I use vaginal progesterone. That is the best what I use. Yes, you have options of using IM and other things. Oral Dufastin also you can use, but I prefer using vaginal progesterone for luteal phase support because see, if you have attended luteal phase support classes, and if I could show you, let me try to search if I have the image. No, it's not here. So maybe sometime next time we will discuss vaginal route, any medication, any hormone. If you give by vaginal route, the maximum amount of the drug reaches the endometrium. So the best route is vaginal. If the second option, if you want, you have dihydrogesterone or what you call as Dufastin. That is the second best thing which you can use. Not second best thing, that is also equivalent you can use, but the cost of the medication is something which I come to because every tab of Dufastin costs around 60 to 80 rupees and you have to use at a dose of 10 mg twice daily. So the dose costing is very high for the patient. So, and sustained tablets are pretty cheaper. They are half the price of Dufastin. So that is the reason of me using. But the patient, what sometimes they'll say there's a lot of white discharge, there is burning, there is itching. Then I might switch to Dufastin if they are not comfortable. Foul smelling discharge also they will say because it do smell very bad when you're using progesterone vaginally. So if no more questions, we can wind up the session. I think we had a good discussion, and I hope you all do join for NIPT session where we can actually debunk the myth of NIPT. This is a very interesting topic, and I love talking about that. So be prepared with your NIPT queries, whatever you have, any case scenarios, clinical scenarios, what you actually deal with in your life practice. Come with the cases. You can post it on the chat. Prior also, you can send in the group and we can discuss all those cases wherever you have dilemma. How to read NIPT report. That is the most important thing.
Thank you, madam.
Welcome. One more question, last question for today. Structural malformation with thin endometrium, should we offer surgery for correction of malformation or medical management? Like, see, what structure malformation you're talking about? Adenomyosis, what surgery we will do? We will treat it medically. Yes, if it's a fibroid which is intending on the endometrial cavity, removing that is going to help you. If it is a structure malformation like adhesion, you are going to remove that. So it depends on what you're dealing with. If there's a endometriosis, if there is, if in your scans you have endometriosis, if the endometrium, if there is endometriosis, means endometrioma you're seeing, if the sliding sign is negative, you're suspecting mild endometriosis, they're also doing a surgery, can be helpful. So structural malformation depends on what structural malformation you're talking about. Sometimes surgery, sometimes medications, depends on the cause. Dietary advice for thin endometrium. Yes, many people prefer giving phytoestrogen things. So many foods are there where the estrogen amount is high, but those things actually, my patient told me some leaves she is using. Somebody has told her. I'm not remembering the leaf name. Ki, ashwagandha or something she said. So there are a lot of phytoestrogens are there, but we all know as allopathic doctors that the amount and the doses of estrogen in those phytoestrogen thing is not fixed. You cannot be sure what amount of, yes, there is some amount of estrogen in them. People use fenugreek, flaxseed, those are good source of estrogen. But the thing is, those things, the regulated dose we cannot give. So that's the reason I don't prefer, but my patient is using, telling me, and she's using. I said, okay, use it, your wish. So don't prescribe yourself. If the patient wants to, they will take advice from so many people, they will use it. But the amount of estrogen which is present in that, you don't know. So we cannot directly comment on dietary advice. Rubella IgG positive, thin endometrium, how to proceed? Rubella IgG positive means the patient is immune. The IgG will never cause anything. So if IgG is positive and if you are concerned about rubella positive IgG, first of all, it's telling you it's immune. If you're thinking of reinfection, which is very, very rare, then what you need to do, please repeat the test after 4 weeks. Look for the titers of IgG, whether there is a rise. If you see a rise fourfold, then yes, there is a secondary infection. Second thing, please go for avidity. If the avidity comes out to be high, rubella is not going to cause anything. That means ideally every lady you should give rubella vaccination preconceptionally and make the patient immune. But now she is immune herself, so that is a good thing. That is a past infection. So that is not going to cause anything. Rubella usually causes fetal structural malformation, specifically if it affects in first trimester. That there to 90% you will have structure 90, if I'm quoting it correct, or 95 also it may go. So now we'll end the discussion because the questions are popping in, popping in. We are not finishing. Okay, we'll wait for 2 more minutes before we end the session. If you have any last question, we'll discuss that. Any day you, if you feel like to have a class on torch also, we can have. Torch is one such topic which we mostly don't deal with, and we don't understand how to read torch report. See, if I tell you torch IgM positive or IgG positive tells you nothing. IgM for torch, for toxo specifically, can be positive for 2 years. So you cannot comment that patient has IgM positive, patient is having toxoplasma, so she cannot get pregnant or whatever. No, it's not like that. So torch is one very dilemmatic topic. So we need to understand that whenever we have such problems. But for IgG, I tell you two things. First, never do a torch test without avidity. Second thing, if you have done torch and avidity is not done, just repeat the torch after 4 weeks and look for the titers. How the titers are rising or decreasing or changing. Okay, sure. We'll do torch class someday. And so please note it down. Someday we'll have 1 hour class on torch infections. We'll do that in fetal medicine per se someday. So thank you all for joining in. We had pretty good discussion. I hope we cleared so many confusions, and now we have something to do tomorrow, something new and something new approach we have. Hope to see you in NIPT class also. Thank you.